Good evening, everyone. Thank you for joining us for tonight's International Dermatology Education Foundation Educational Series webinar. My name is Ashley with RBC Consultants. The title of tonight's webinar is Expanding AD Options for Adults and Pediatric Patients 12 years of age and older with moderate to severe atopic dermatitis. As moderator this evening, we have Dr. Firas Hougier, Clinical Assistant Professor, Department of Internal Medicine, Philadelphia College of Osteopathic Medicine, and President of Southeast Dermatology Specialists. As speaker this evening, we have Dr. Raj Shovatia, Northwestern University, Feinberg School of Medicine, Chicago, Illinois. We would like to thank our supporter this evening, Pfizer, for making this educational event possible. A couple of logistic tips before we begin. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane, and the audio and the dial-in information will be displayed. If you're having technical issues, or if you would like to submit a question to our faculty, please submit your questions in the question pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and will also be emailed to you within 1 to 2 days. We would greatly appreciate it if you could fill in this short survey. Also, within 1 to 2 days of the webinar, you will receive a certificate of attendance. Again, we will have a Q&A portion at the end of the program, so please submit your questions using the question pane on the right-hand side of your screen. So without further ado, I would like to introduce Dr. Firas Hougier.
Good evening. Thank you for being here today. It is my distinct pleasure of being here with you for yet another International Dermatology Education Foundation seminar. We today have the pleasure of having Dr. Shovatia at our IDEF seminar. As you know, the IDEF is a nonprofit organization whose principal mission is to raise awareness and improve dermatologic care all over the world through education, and especially in underserved areas. Dr. Kircik, Leon Kircik, a dear friend of mine, is the president and founder of our foundation. And as we know, he's a clinical professor in dermatology at the Icahn School of Medicine, Indiana University, as well as a medical director of a research center in Kentucky. We have had multiple different sessions. The IDEF had multiple sessions in the past with many of distinct faculty, such as Dr. Brad Glick, Dr. Song, Dr. King, amongst other, and this is Dr. Adelaide Hebert, as you can see on the left side. So many educational sessions have been seen by many of you guys, hundreds in each, and we're happy to continue with this tradition today. Today we'll have Dr. Shovatia, who will talk to us about the expanding atopic dermatitis options for adults and pediatric patients 12 years or older with moderate to severe atopic dermatitis. Dr. Shovatia is a board-certified dermatologist in Chicago with a clinical research focus that includes the intersection of cutaneous immunology and inflammatory disease. He received his medical degree and PhD in immunology from Yale University and completed his residency at Northwestern University, where he also served as chief resident. Dr. Shovatia, it's great to have you here with us today, and we'll pass the mic to you.
Thank you so much for a very kind introduction, Firas, and welcome everybody to what is hopefully going to be the highlight of your week as we talk a little bit about atopic dermatitis therapy, and in particular, thinking about sort of expanding that across your patients from 12 years of age and up. As you heard, my name is Raj Shovatia. I'm based out of Chicago, and I really love educating and talking about what is possible when we think about treatment for our patients with atopic dermatitis. And it's really been kind of a whirlwind over the past year, if not 2 years, just given how many new treatments have either emerged, are a part of our toolbox, or will be a part of our toolbox in the next decade or so. So one of those is Sabinco, which is what we're going to be talking about today. You may know it by its other name, abrocitinib. And the title of our talk is Expanding Atopic Dermatitis Options for Adult and Pediatric Patients 12 years of age and older with moderate to severe atopic dermatitis. So of course, this program is being sponsored and paid for by Pfizer. I am a paid consultant for Pfizer as well, and I'm presenting on behalf of the supporting company, and together, everything we're going to be talking about today is by the book in terms of FDA compliant guidelines. So our overview of what we're talking about today, we're going to be talking about Cibinqo, small molecule JAK inhibitor that works inside of the cell. We're going to be talking about efficacy. So we're going to talk about the JADE clinical trial program, how it was set up, who were the patients, how does that relate to what you think about in terms of atopic dermatitis. And then we're going to think about sort of beyond just efficacy, we're going to talk about safety, which we know is huge for our patients and oftentimes the most important thing that they want to talk about even before we have that discussion about efficacy. Finally, we're going to talk about how we might go about starting and monitoring our Cibinqo patients as well. So remember, Cibinqo is indicated for refractory moderate to severe AD. I love having this discussion start off with the indication because hopefully we understand why we're here and what it's for. If this is not the drug that you're here for, you're in the wrong webinar. But Cibinqo is indicated for the treatment of individuals 12 and up with refractory moderate to severe atopic dermatitis. We'll talk about what that means in the context of the trials, whose disease is not adequately controlled with other systemic drug products, including biologics, or when those therapies are inadvisable. So essentially somebody who is not getting what they want to out of their current therapy, whether it be a systemic drug, that could be a biologic, that could be anything else, or when one of those may not be the right choice for somebody as well. There's certain limitations of use as well that are right on the label, and that simply is just based on the fact that this has really only been studied as monotherapy and in combination with topical corticosteroids. Important contraindication just to be aware of with Cibinqo, for those taking antiplatelet therapies except for low-dose aspirin, you're not going to be wanting to concurrently treat here in the first 3 months of treatment. And there is a boxed warning. If you've heard about JAK inhibitors over the past few years, you're familiar with this, but we're going to talk about this in the context of some important safety data from the JADE clinical trial program, but also in terms of a broader context when thinking about the overall epidemiology of atopic dermatitis itself. So our framing narrative overall today is going to be thinking about Tyler. Hopefully Tyler, who's a 21-year-old college student, reminds you a bit about some of your patients. He has moderate to severe atopic dermatitis. He's been experiencing uncontrolled symptoms, using topicals multiple times a day. He's been treated with topical corticosteroids. He's received an injectable biologic. And a quote from Tyler, "I've been on multiple different treatments, so I guess this is all the relief I'm going to get." And really this resignation of where I am is where I'm going to be stuck is really so commonplace for atopic dermatitis, and it doesn't have to be. And let's start from there. So when we think about the pathophys of atopic dermatitis, I promise you we'll keep the immunology to sort of the bare basics here over the next couple slides before we jump into the most clinically relevant part. We know that with the cutaneous immune dysregulation that occurs in atopic dermatitis, it's a veritable alphabet soup of cytokines, soluble protein mediators that bind to receptors on epidermal cells and immune cells and orchestrate the inflammatory response. IL-4, IL-13, 22, 31, thymic stromal lymphopoietin, interferon gamma. All of these are different cytokines that signal through different kinds of receptors, but all use similar core machinery to transmit these concepts of itch, inflammation, and even skin barrier disruption. And for those of you that may not be entirely familiar with the JAK-STAT pathway, the JAK-STAT pathway is a signal transduction pathway, or really a fancy way of saying one of the core conserved evolutionarily important mechanisms we use in the body to transmit signals from point A to point B. In this case, point A being the outside of the cell from one cell, point B being the inside of another cell. And you're kind of trying to figure out how a soluble protein can tell a cell what to do and change its transcription and translational program. And this is where JAK-STAT falls in. So JAK stands for Janus kinase, named after the Roman god of duality. There's 4 JAK proteins, JAK1, JAK2, JAK3, and TYK2. They work together in pairs on the intracellular aspect of cytokine receptors. And upon binding of an actual cytokine to the outside of a receptor, they become activated, causing phosphorylation of the receptor itself, which allows docking for STAT proteins, signal transducers and activators of transcription, which once phosphorylated and activated can actually float on into the nucleus and become a part of the transcriptional apparatus and actually cause downstream transcription and translational changes. And that oftentimes in atopic dermatitis means productions of oodles and oodles of more cytokines and various other molecules involved in this inflammatory process. Now, where does Cibinqo fit in all this? Well, Cibinqo is an oral small molecule JAK inhibitor that works on the inside of the cell at these JAK proteins. And in particular, it's a small molecule and not a biologic, meaning that it does not work at a receptor on the outside, but traverses its way through the cell membrane and reversibly inhibits the JAK1 protein preferentially over JAK2, 3, and TYK2 based on data we have from cell-free enzyme assays by blocking the ATP binding site. ATP being the currency of these proteins, JAKs tend to turn ATP into ADP and attach that phosphorus group to the stats and the receptor itself. And so by preventing that activity, no more activated stats, no more activated transcriptional activity, and that way you modulate it. There's reduced cytokine production, and overall you're kind of cutting off inflammation at a fairly high source. So logically, it makes sense why that might be a mechanism of interest. So when might you want to consider Cibinqo? When you're thinking about powerful skin clearance, of course. When you're thinking about rapid itch relief, makes sense to me. When you're thinking about flexibility, of course. So really sort of different parts of the story that fit with what you're thinking about for Cibinqo. So we know that in the case of skin clearance, there were patients that saw 75% improvement or more in their skin, clear or almost clear skin at week 12. Rapidity of itch relief early here is week 2, and rapid and significant relief even without topical corticosteroids and in comparison to other medications. And flexibility, where you have 2 doses of Cibinqo, 100 milligrams and 200 milligrams, and that 200 milligrams on label currently is a consideration for somebody that may not be where you want them to get at 100 milligrams after 12 weeks. The last point here is the box that's all the way at the bottom, and it's a well-studied safety profile. And that's going to really occupy a good last third of our time together. So it's something that I think we all take very seriously, but is important to place in the right context with those points above, which are oftentimes one of the first things that we think about honing in on as dermatologists. So Tyler's back to us here again. He says that he's in college right now and concerned about having visible eczema on his skin with constant itching. Echo that, and sounds very much like any one of my young college students might that I see as well. So let's talk a bit about powerful skin clearance and rapid itch relief. So Cibinqo was studied as monotherapy as well as in combination with topical corticosteroids. So the JADE Mono 1 and Mono 2 trials were parallel, randomized, placebo-controlled trials for 12 and up. They were monotherapy, so no concurrent topical corticosteroids. JADE Compare was a 16-week combination therapy study that allowed for topical corticosteroids, though the primary endpoint here was at week 12. And there was an active control arm of dupilumab along with Cibinqo 100 milligrams and 200 milligrams and an oral or injectable placebo. It is important to note that in this particular trial, while not a direct head-to-head trial in terms of design, there is an endpoint at 2 weeks that is used to make some comparative efficacy in terms of statistical analysis based on the trial design, and we'll delve into that. Finally, in the case of JADE Teen, this was a trial dedicated to individuals who did 12 and less than 18, 12 weeks again, and really looking at individuals in that real world setting that might be using concurrent topical corticosteroids. We're also going to talk about a little data from JADE Extend, which is an ongoing long-term extension study for eligible patients who completed a qualifying JADE parent study. We're going to touch on a post hoc analysis that was done taking a look at some of this data, meaning that it was not specified initially in terms of trial design. And we're also going to look at an interim analysis of the JADE Extend program. So when thinking about what patients look like in these clinical trials, there was quite a bit of disease severity, right? So maybe about 2/3 moderate, 1/3 severe when you're thinking about sort of your use of IGA scores. The mean EASI score was around a 30. It's at a scale of 72. So 30 firmly puts people actually in a severe range based on EASI score. Many people in the Mono 1, Mono 2, and Compare studies had been on a prior systemic therapy with very low rates, but sort of measurable rates of dupilumab use. And that was mainly the Mono 1 and Mono 2 component, where there was no dupilumab treatment arm in the studies. And then in terms of age, again, you're looking at sort of around 36 for median in the Mono 1 and 2 and Compare, and about 15 years for the teen study that focused on that 12 to 15 group. So let's kind of talk about a few high points since we don't have an entire night together to go through every single disclosure that's been shared over the past few years. And this is a highlight from JADE Mono 2, and the data from JADE Mono 1, is sort of quite parallel and very, very similar. So this is just for simplicity and ease. So in terms of thinking about EASI 75, which remember is that endpoint that looks at 75% improvement or more in the EASI score. The EASI score being the Eczema Area Severity Index, a composite measure of body surface area, location, and severity. You can see here that nearly half of patients on the 100 milligram dose and sort of more than 60% on the 200 milligram dose achieve that EASI 75 at 12 weeks. You can see that about fourfold more improvement versus placebo when comparing to Cibinqo 100 milligrams and sort of even higher values on that Cibinqo 200 milligrams. If you're thinking about the IGA 0/1, which is the other co-primary endpoint, again, about nearly 30% and 40% for 100 and 200 milligram doses respectively, compared to just under 10% in the case of placebo. Now, of course, numbers and graphs can be helpful, but here's some images to sort of maybe give you an idea of what was seen in the trials itself. And so these are just some examples representatively taken from the trials. What you're seeing here is images from Mono 2 of an individual that was treated with 100 milligrams who started at moderate here. You can see week 2, and then at week 12, they had a 1, so they're almost clear with just barely perceptible erythema in that photograph. You can see here on the left-hand side, this is an individual that again started at moderate, 53-year-old female. This is taking a look at the shin. Again, across Mono 2 goes from 3 all the way down to 1, being almost clear. And then finally taking a look at the calf on this individual with slightly darker toned skin. So you'll notice a distinctly different look in terms of what the erythema appears like here. This is an individual who started at severe and actually went down to a moderate. So this would actually be an individual who did not meet the co-primary endpoint based on the definitions that we just talked about. But I would say, just looking from a clinical standpoint, you can see even what 1-point improvement, what that may look like. So I always think it's great when you take a look at what theoretically was quote unquote by trial protocol considered a non-responder, which clinically you can sort of see a very stark difference in that lichenification, thickness, and erythema in this patient. So let's take a look at sort of some of the JADE compare data next that allowed for concurrent topical corticosteroids. And this is again looking at EASI 75. And you can see here about 6 out of 10 patients achieved this EASI 75 benchmark, or 75% clearer skin is the other way to think about it, with Cibinqo 100 milligrams in only 12 weeks of time. And you can see sort of nearly 7 out of 10 patients for the Cibinqo 200 milligram treatment arm. Dupilumab sort of finishing very similarly in terms of taking a look at the Cibinqo 100 milligram treatment arm. And of course, really looking at the actual placebo arm, which included topical corticosteroids at well under 30%. Now, if we're taking a look at clear or almost clear skin here again, you can see that about more than 1/3 of patients achieved clear or almost clear skin with that 100 milligram dose in 12 weeks. And that corresponds to nearly about half of patients on that 200 milligram dose at that 12 weeks. And you can see there's consequently dupilumab sort of right around where you see comparatively in terms of that 100 milligram Cibinqo dose. But remember, this was not a head-to-head study in the formal statistical sense, but rather was an active comparator, which of course allows you not to really kind of compare these directly, but give you a reference frame in terms of what you're looking at. Now, what about EASI 90? So thinking about individuals that are 90% or more improved from baseline. And of course, this was, a pre-specified endpoint, but it was not controlled for multiplicity. So really you can't interpret this with the full statistical veracity that you've done the other primary endpoints. But you can see here that nearly 40% of patients actually hit that benchmark at week 12, and you're getting closer to about 50% of patients at week 12 in terms of that 200 milligram dose as well. So let's go back to some pictures, because again, those graphs might be putting you to sleep, but pictures are always going to be when dermatologists decide to lock in. So this is an individual that was 21 years old that was in the COMPARE trial, and he started off as being severe. You can see what that IGA-4 looks like. And on the 200 milligram dose, you can look at that total clearance at the week 12 time point, but you can also see that progression going from baseline to week 2 all the way to week 12 as well, where there's no longer any erythema or any excoriation, mainly just some post-inflammatory hyperpigmentation that you're seeing. Additionally here, taking a look at the abdomen, where you can see quite a bit of excoriation and erythema, starting at a severe at baseline, you can already start to see sort of definite clinical differences in the photos between baseline and week 2, and then looking at the total clearance at week 12 again with maybe some trace post-inflammatory pigment alteration, otherwise no active signs of atopic dermatitis. So I kind of want to highlight another analysis that stems from the actual JADE Compare and JADE Mono and Mono 2 data. And this is the JADE Extend long-term extension study that has essentially allowed individuals who were on these therapies to roll over into a longer-term treatment arm to week 92. And then those who were eligible could then sort of go into an open label treatment period. Now, in this particular study designed, Sabinco 100 and 200 milligrams were all the way through treatment, whereas individuals previously receiving placebo were randomized to either dose of Sabinco as well. And sort of secondary endpoints here looked at EASI-75 and IGA-01 at all scheduled time points, but safety is typically going to be the primary thing that you're looking at in a study like this. So taking a look at this data, and you can see here analysis all the way up to 48 weeks, you're seeing a few different lines. And the big thing to take away from here is that you're looking at sort of long-term skin clearance responses. Now, we know that, just for anybody that is thinking about it, these are ad hoc analyses, and so there's no adjustments for multiplicity, which is why you're not seeing p-values, stars, and pluses, things that you're used to in the primary treatment period. And this is how we tend to handle all of our long-term data. And you're also seeing a few different lines here as well, in terms of an as-observed line in the solid, and then a non-responder imputation. Two different ways to look at data where you're kind of looking perhaps a little more realistically in the as-observed arm of people that are staying on therapy versus a non-responder imputation that is going to take a more stringent view to individuals starting or stopping or dropping out for any reason whatsoever as failure. Now, the most important thing that you're seeing here, though, generally is after that 12-week period, relative stability forward in this treatment period. So kind of almost a horizontal line as you draw it across. And that's typically what you're going to be looking for when you're talking about long-term skin clearance or durability in these types of responses as well. It's also important to note long-term treatment period. Of course, there's going to be biases to who stays, who doesn't stay on period. There's a lot of difficulties in designing this, but I think that maybe the most important thing to take away is sort of that relatively horizontal stability that you look for in terms of clearance responses. This is taking a look at IGA-01 and JADE Extend, and again, you're seeing something very, very similar. If you take a look at sort of that as-observed arm, just as for example, about 40% and 50% respectively for Sabinco 100 and 200 milligrams by the end of week 48 when following those people all the way along this treatment period with the same caveats that we just discussed. Now, I think that one of the more interesting analyses that sort of gives us maybe a picture of questions that we frequently get from either our patients or our colleagues, what theoretically may happen for somebody that was previously on a different treatment and then ended up switching over to another treatment. And so in this case, this is what this post hoc analysis is taking a look at. If you remember in JADE Compare, there was a dupilumab treatment arm, 300 milligrams every 2 weeks. And in the course of that study, by the end of week 16, there was a really easy way to take a look at, did people respond by various criteria or did they not? So, by respond or not, you could look at EASI-75, you could look at EASI-90, you could look at an IGA-01. And, by the end of this treatment period, 16 weeks, after a 4-week oral placebo washout, individuals would then randomize into Sabinco arms for longer-term treatment in the JADE Extend study. So in this way, you can actually take a look at the individuals who were on dupilumab, but let's say did not meet an EASI-75, which was 51 individuals, did not meet an EASI-90, which is 105, or did not reach an IGA-01, and then take a look at how they did in an equivalent time period on Sabinco 100 milligrams and 200 milligrams. And we talked a little bit about sort of what a post hoc study looks like in terms of limitations as far as statistics go. That's what's demonstrated on this slide here. I told you a little bit about this. There's no placebo control. This is longer term data as well, so it's not all the patients. So the general same limitations still apply. However, what you can see here is that when you're taking a look at individuals that did not get clear or almost clear on dupilumab, 35 and 47% respectively with Sabinco 100 and 200 milligrams actually achieved that clearance or near clearance at week 12. In terms of EASI-75, nearly 70% and 80% on 100 milligrams and 200 milligrams also achieved that endpoint. And with EASI-90, about 4 out of 10 and 6 out of 10 patients on the 100 and 200 milligram doses achieved 90% improvement or more and did not previously achieve those endpoints on dupilumab as well. And so I think that with that data in hand, and I'll kind of go back to that slide for just a second, obviously difficult to make sort of strict statistical comparisons, but really important data I think that is helpful when I'm really trying to think about all the numbers and all the treatments, or maybe even fielding questions from patients as well. So if we focus on our pediatric group for a moment, J-Teen, if you recall, was a dedicated trial looking for individuals 12 to less than 18. You can see here that about 64% of pediatric patients achieved clearer skin with Cibinco 100 milligrams in only 12 weeks, and that number goes up to about 71% in individuals treated with Cibinco 200 milligrams. Additionally, when taking a look at clear or almost clear by that IGA score, about 4 out of 10 and nearly 5 out of 10 patients for 100 milligrams and 200 milligrams respectively, compared to less than 25% for patients that were treated with placebo in this case, which allowed for topical corticosteroid treatment. If that looks very, very familiar to what we saw in the trials of 12 and up, it is not a coincidence. You can see a high degree of consistency between teen compare mono 1 and mono 2. So I talked a little bit about some of that earlier time point data at week 2, and this is an analysis looking at individuals achieving a meaningful clinical improvement in their itch. So if you remember, we use a peak pruritus NRS scale, which is kind of 0 through 10, how bad is your worst itch? And that's a very, very valid tool in both real world practice and actual clinical trials. And this is taking a look at individuals who had a 4-point improvement or more on that scale. So if they were at a 7 out of 10, they have to get to at least 3 out of 10 or lower. So you can see here that, taking a look at Jade Mono 2, at week 2, about 11% and 24% respectively compared to 2% of placebo patients treated with Cibinco 100 milligrams and 200 milligrams experienced that itch relief versus placebo. So you could say about 5-fold more patients taking Cibinco 100 milligrams, and that goes out about 10-fold more in terms of Cibinco 200 milligrams got there versus placebo. Now, in terms of thinking about sort of what that change looks like over time, so the absolute change, which again is going to be sort of, do they go 1 point down, 2 point down, 3 point down, as opposed to looking at the proportion of individuals hitting that 4 point. So no longer a kind of discrete variable, but rather a continuous variable. You can see this sort of very, very steep drop over the course of the first 2 weeks, all the way down to sort of about 2 to 3 points down on the 10-point scale. And that continues to linearly decrease over the course of the remainder of the trial down to week 12, where you're seeing sort of least square means change in that itch score greater than 3 and even sort of 4 points down for where individuals started at as well. So I did promise there was going to be sort of one more comparative piece of data here, and this was from the JADE Compare study, taking a look at individuals achieving that itch improvement, 4 points or more at week 2. And so you can see here that Cibinco 100 milligrams, about 14%, 30% in terms of Cibinco 200 milligrams compared to about 8% of placebo, and about 13% of dupilumab as well. So of course at week 2, higher proportions achieved these particular endpoints compared to placebo. And at week 2, about similar proportions achieved the itch relief with Cibinco 100 milligrams and dupilumab, but a higher proportion treated with Cibinco 200 milligrams were able to get there compared to dupilumab as well. So now that we've had a good chance to talk about efficacy as it relates to thinking about lesional clearance, both on monotherapy, combination therapy, we talked about long-term data, what does that look like? And we talked a little bit about sort of short-term data in 2 weeks, both sort of comparing to placebo and thinking about kind of other treatments in the presence or absence of topical corticosteroid. Let's talk a little bit about safety. And Tyler here says that I'm open to a new treatment, but I want to better understand the potential side effects. Tyler, I'm with you. I feel like many of my atopic dermatitis patients, this is going to be sort of the bulk of what we talk about. And so on this slide, you can see here some important safety considerations that are highlighted. And you'll see words like serious infections, mortality, malignancies, major adverse cardiovascular events, and thrombosis. The elements of the boxed warning that are exhibited on all JAK inhibitors for inflammatory disease, which includes Cibinco and atopic dermatitis. So it's important to note that in the case of serious infections, sort of increased risk of bacterial, viral, fungal, and opportunistic infections sort of have been reserved in JAK inhibitors for inflammatory disease. In the case of Cibinco, the most common things seen were herpes simplex, herpes zoster, pneumonia, and then the recommendation here is to do some baseline screening on your patients before starting and avoiding treatment with someone that has active or serious infection. Now, in the case of the other points on here, you'll note that there is repetitive wording that seems to come up in each of these statements that talks about a long-term clinical trial on patients that were over the age of 50 with one cardiovascular risk factor that were treated with another JAK inhibitor for their rheumatoid arthritis compared to TNF-alpha inhibitors. And this is in reference to the long-term oral surveillance study that was conducted during the 2010s, looking at tofacitinib, a different JAK inhibitor, for a longer period of time among individuals with rheumatoid arthritis. And we'll kind of touch on this for a second, but this is kind of where these particular principles come from: mortality, malignancies, major adverse cardiovascular events, and thrombosis, as these were sort of observed to be at sort of slightly higher rates than individuals not treated with that JAK inhibitor. And so you're generally going to be avoiding Sabinco in patients at risk. Of course, individuals in this sort of longer term trial with a different JAK inhibitor that were smokers or previous smokers were at higher risk. But overall, you want to do a good job of reviewing the systems of your patients and sort of figuring out who might be at the highest risk. Now, talking a little bit about that study in more detail, I sort of mentioned tofacitinib's post-marketing study. It's important to note that in this longer-term study that really sort of led to this revised labeling that we talk about, these were individuals, again, that were sort of over the age of 50, had at least one cardiovascular risk factor, were all on methotrexate, about 50% or so used oral corticosteroids, and then again, sort of your treatment groups here were TNF-alpha versus tofacitinib. So really, one of the only ways that you can end up looking for rare events over a long period of time is to enrich the study population for those that may be of interest. And that's kind of the way that this study was particularly designed, looking for a co-primary endpoint of a non-inferiority margin for adjudicated major adverse cardiovascular event and malignancy. And so this was kind of an event-driven study where individuals were followed kind of for the primary outcome of interest. So it's just important to note where this comes from. I think that, you know, some 30-second description of this is oftentimes what ends up going into my discussion with patients to provide some appropriate context behind what we just talked about on the previous slide. So with all that being said, let's talk about safety from the JADE clinical trial program and try to put this in context. So you can see here that these are adverse events of special interest, sort of those quote unquote bolded things that we just saw on the previous slide, up to 16 weeks. You can see placebo, Sabinco 100 milligrams, and Sabinco 200 milligrams in these three columns. And you can see serious infections, herpes zoster, all the way down to deep venous thrombosis in this column. So what you'll note is perhaps sort of a few cases of herpes zoster that appear to be sort of dose dependent here. Serious infections fairly consistent overall across all three arms for treatment. And overall, not much happening in the way of malignancy, non-melanoma skin cancer, major adverse cardiovascular event, and pulmonary embolism as well. So this is one of those circumstances where we're seeing a lot of zeros is actually sort of very, very helpful. And of course, this is sort of shorter term data, and sort of, you know, we know that the trials can be occurring under a wide variety of conditions. And so the general caveats sort of looking at longer and shorter term data here apply. But what if we were to look at sort of more patients having exposure, perhaps even up to 2 years? And this is taking a look at individuals from JADE Extend, includes individuals that had at least 48 weeks of exposure, and here about 554 patients had at least 96 weeks of exposure. And so you can see here that there was a total of more than 1,000 patient years followed for Sabinco 100 milligrams and Sabinco 200 milligrams. And you'll note again that the serious infection sort of rate that we saw on the previous slide sort of remains relatively consistent, sort of cases of herpes zoster that again appear to be somewhat dose dependent. And again, in terms of malignancy, MACE events, pulmonary embolism, and deep venous thrombosis, you can see sort of rare reported events here across both of these arms too. Now, it can be sort of very difficult to figure out how to interpret this, just because, you know, long-term extension studies can be helpful for some of these low frequency, long latency adverse events. But we also know that, you know, in general, not everyone may stay on the long-term treatment. There's various biases possible, sort of when blinding ends, what do you do about that? At that point in time, people may enter and exit this period too. The number of observed patients with longer exposure time sort of becomes lower over time. So it's really helpful, I think, to really look at this data and sort of kind of see the numbers, but understand that there's limitations on sort of truly what you can kind of conclude from this sort of story. But I think in a piece of this story that might be very helpful for you in terms of putting your mind in the right context, how does this maybe stack up to what you might see in the real world? And so it's impossible to really compare randomized clinical trials and real-world observational studies because they're just not statistically designed to do so, and they're just different study designs. One is interventional, one is observational. Typically, clinical trials are prospective, whereas real-world studies are usually retrospective, and you're not defining exactly a priori at the moment what you're going to be gathering going forward. Clinical trials, you have a highly monitored population. I mean, in the case of real-world data, it's a pretty broad patient population, and these can kind of vary with what you're doing. As far as treatments go, truly random in a clinical trial, not exactly completely random in the case of a real-world study. As far as outcomes, prospective studies like clinical trials can show causality. You're really showing associations in real-world observational studies as opposed to causality. So you can't really compare them directly, but it can be helpful to have this data on hand to at least give you some framework and reference to understand the data that you might be looking at. So we've summarized the data on the top here for looking at some of those select adverse events in patients taking Cibinco in clinical trials. You can see the MACE events, venous thromboembolic events, and malignancy. And then on the bottom, what you're looking at is a newer analysis of retrospective data from a demographically matched cohort of patients with atopic dermatitis in the Kaiser Permanente medical system between 2007 and 2018. So this is looking at more than 8,000 patients and trying to understand what does the incidence rate look like in terms of every 100 patient years for MACE events, VTE, and malignancy. So you can again see the numbers for reference with Cibinco 100 milligrams and 200 milligrams. And when looking at just all comers, patients with atopic dermatitis here, you can see MACE events 0.26, VTE 0.20, and malignancy 0.44. And then you can kind of take a peek back, look at that table up there. So, you know, like I said, while you can't really directly compare these just given totally different studies and totally different designs, the outcomes that you're measuring may have sort of limited sensitivity, specificity, et cetera. I find this all to be very helpful to me to really sort of understand how I might sort of present some context behind this discussion when I'm really trying to go through what otherwise may seem like numbers out of the blue that sort of are not easily able to resonate with somebody. Now, in terms of the most common adverse reactions overall, like greater than 1% that were seen in patients taking Cibinco for up to 16 weeks, you can see at the top of the list nasopharyngitis, which sort of was elevated in the placebo group as well. Nausea, perhaps, is the most notable one here, which sort of has some degree of dose dependence. Headache, you can see sort of lower rates of herpes simplex, blood CPK increases, dizziness, UTI, and I won't read every single one, but takes us to near the end of the list in terms of herpes zoster and thrombocytopenia, looking at the right-hand column as well. In terms of discontinuation rates as well, generally you're seeing sort of relatively low discontinuation rates for Cibinco 100 milligrams and 200 milligrams compared to placebo. And the most frequent adverse event leading to discontinuation rate was atopic dermatitis, of course, which occurred more frequently in the placebo group. And the others that were sort of leading to discontinuation that were more common in the Cibinco group were nausea and headache at 0.3% and 0.2%. So I think kind of the clinical trial data that's very helpful for those of us that do these kinds of studies. So kind of in the last few minutes that we have here together before we bring Dr. Hajir back on, I really want to talk about some of the nuts and bolts behind maybe sort of starting your patients on Cibinco and what that may look like. So of course, we talked a little bit about dosing. The recommended starting dose for individuals is 100 milligrams a day. If you don't get to where you want to in terms of an adequate response, which can be many of the parameters we talked about after 12 weeks, you want to consider increasing dosage to 200 milligrams once daily. You can take this with or without topical corticosteroids. Take it with or without food. If nausea is something that somebody experiences, sometimes it helps to take medicine with food. Swallowing the tablets whole are what you want to do because that's where the magic is in terms of extended release. And Cibinco 50 milligrams, even though data not sort of talked about here, is available for dose adjustments in special populations based on who might be strong inhibitors or poor metabolizers of CYP2C19. Additionally, when thinking about patients that may have renal impairment, of course, not recommended for those with severe renal impairment. For moderate renal impairment, sort of 50 or 100 is what you're going to use as opposed to 100, 200. It's not recommended for those with severe Child-Pugh hepatic impairment. And just some important information listing for those that might be on strong CYP2C19 inhibitors. Inhibitors of both C19 and C9, sort of strong inducers, P-glycoprotein substrates like digoxin or antiplatelet therapy drugs, which we talked about, holding off in the first 3 months except for low-dose aspirin, given that that's a contraindication on label. So this table should hopefully give you the most poignant and direct summary of what you may think about in terms of evaluation and monitoring for your patients. At baseline, thinking about taking a test of TB and viral hepatitis status is something sort of I would do, and it's right here on label, and then taking a look at sort of CBC. And as far as labs go, generally, that's going to be it. And then what you may be looking at 4 weeks after initiation or a dose increase would be another check of CBC and lipids. But beyond that, if all else is stable, then it's sort of up to kind of clinical guidance based on you as the expert in terms of what might be the best time to periodically evaluate some of these things. When it comes to immunizations, the goal here is to sort of generally get your patients to stay on top of these, and of course not use sort of live vaccines while on therapy like with most other systemic medications. In terms of Mason thrombosis and malignancy, generally just doing a good job asking your questions about patients. Hey, how's it going? Breathing okay? Any new onset leg swelling, chest pain, anything like that, which I think can also be very helpful. And then of course, advising females of reproductive potential that Sabinco may impair fertility, and reporting pregnancy or pregnancy registry that's listed right under here at a phone number and website. You wouldn't be wanting to initiate treatment in somebody who has sort of various lab values below some of these low thresholds that are indicated here in terms of platelet count, hemoglobin value, et cetera, that makes them have some type of cytopenia across the blood cell count panel. Additionally, you'd want to discontinue or interrupt therapy if somebody developed an infection or some of these lab values crossed below some of these thresholds too. So in terms of lab abnormalities in patients taking Sabinco, that's what's listed over here. You can see by and large lymphopenia below an absolute lymphocyte count of 500 was quite rare. Lipid elevations were sort of rarely seen too, perhaps a bit more in the Sabinco 200 milligram group, and then creatine phosphokinase elevations across all the groups, knowing that this is a highly fluctuant blood factor to take a look at, we're also seeing as well. And then across 5 trials, including the long-term extension data, you can see here sort of a few cases of thrombocytopenia in the Sabinco 200 milligram group, but not on the Sabinco 100 milligram group. So who might your Sabinco patient be? If you really want a little bit of a mental jog to understand how this may fit into your practice when you're thinking about your moderate to severe patients. Well, in the case of Tyler, he feels like he's been doing everything he can to address his AD, and he's ready for something different. And he sat through perhaps my shorter version of this kind of discussion to sort of talk a little bit about some of the data and what's out there. And in his case, he's using moisturizers. He's previously treated with topical corticosteroids and has used an injectable biologic. And he just has persistent pruritus, scratching throughout the day, eczematous lesions on the face, neck, dorsal hands, arms, legs, about a quarter of the body affected with a moderate IGA score. And so, I mean, I think that in the case of our example patient, or everything we talked about today, really the points that you want to think about for your individuals 12 milligrams and up when it comes to thinking about Sabinco, whether you want to touch on powerful skin clearance or rapid itch relief, maybe flexibility as far as dosing goes, the fact that it is an MOA that involves a small molecule JAK inhibitor that works inside the cell, something that's been studied across thousands of patients for a number of patient years across multiple clinical trials, and of course, you know, various access programs through Pfizer portals that you might be familiar with as well, including copay savings card and personalized assistance to really help your patients stay on top of that treatment journey when it comes to thinking about chronic disease. So some important safety information just to touch on before we kind of wrap some of these things up here. We talked a little bit about sort of lab abnormalities and how we might go about lab screening. We touched on immunizations as well. We touched on renal impairment and hepatic impairment too, and so I'll save you guys from me reading from these word for word. We talked about the adverse reactions that are most commonly seen across 100 and 200 milligram doses as well. As far as drug interactions go, generally you want to make sure you're taking a look at any P450 inhibiting and activating medications. I usually make myself a little list that I keep track of right at my computer so I can make sure that I'm just doing a quick check if I was thinking about abrocitinib. And you of course want to monitor appropriately or dose titrate AP glycoprotein substrate like digoxin, where a small concentration may lead to serious or life-threatening toxicities. We touched a little bit about sort of use in pregnancy with sort of more data needed, of course, but there's really not sufficient data to establish drug-associated risk for major birth defects, miscarriage, or other adverse maternal or fetal outcomes at this time. And hopefully that registry will give us more information. And women should generally not breastfeed during treatment with Sabinco and for 1 day after the last dose. It's the last slide I have for you guys, and so I just want to thank you for having me, and I'm very, very happy to take any questions that may have come up or any questions that Dr. Hujier has rattling around in that busy brain of his. So thanks again, everybody.
Thank you, Dr. Sabatia. Great presentation. I appreciate it. And we all do. It's really interesting with the options that we have now for our atopic dermatitis patients, and Sabinco being one of the ones that really gets us quite a bit of efficacy in the right patient. A few questions came up. One of them, could you expand on the fertility issues and impairment fertility when it comes to using Sabinco in female patients? Is it while you're taking it or for a while after that?
Yeah, so I mean, obviously, while not a heavy component of this deck, that references into mice data and data that sort of exists beyond sort of humans. It hasn't really been studied in humans, that capacity. So it's just from some smaller basic models, and it was while individuals were on therapy itself. I mean, beyond that, I know that sort of your medical colleagues at Pfizer would be happy to tell you more, but that's where that wording comes from, which is why in the label it's written as such that there isn't any data at this point in time to actually sort of answer that question other than mouse related studies. And this was sort of when mice were specifically on therapy.
Thank you. And any reasons not to prescribe it in anybody with diabetes?
Yeah, also a good question too. You know, usually when I'm thinking about my checklist for my patients, I like to tell people that the choice of a therapy is never really black and white, and it's really always gray, because you're going to always be thinking about what are the pros and cons of any particular therapy. In the case of a JAK inhibitor, I think that going through some of those things on the boxed warning about whether or not this is going to be the right candidate or not is important. But given just how common things like hypertension, diabetes, et cetera, are in my patients, a good chunk of my patients have those comorbidities on therapy in the real world, and there's nothing on the label that suggests that you shouldn't use it. In fact, in terms of the exclusion and inclusion criteria of the trials, these were not excluded patients as well. So I would say, generally speaking, not something that's going to necessarily stop me a priori from prescribing a medication.
Good, me either. I haven't had issues with prescribing in diabetes patients. We just discussed the risks factors like with anybody else. Another question that came from the audience. We talked about fertility in females. Does it have any mutagenicity for sperm in males?
Not something that's been investigated, not to my knowledge. Again, I'm happy to toss that one back to the Pfizer Medical, but from my understanding, the last time that I reviewed this data, nothing that I'm aware of.
Okay. And last question to wrap up. We talked about the labs that are advised. What labs do you do?
Great question as well. So I really try to keep it easy for the patients, because, and this is me speaking to my clinical experience a bit now, generally the lab burden is pretty low. So at the starting point, like many of our systemic therapies, you're going to be doing a hepatitis B, C, and an interferon gamma release assay for TB. And then from an actual blood panel standpoint, CBC, and I may do a lipid at baseline if I can't find one that their primary care physician or somebody has done. Beyond that, really, it's only after 4 weeks that you're going to do a lab check of a CBC and an LFT and a lipid. And if things are good at that point, it's fairly infrequent in my book that I have had needed to check labs on individuals. And so it's driven a bit by patients when they're going to follow up and what a burden is for them. But for me, you know, as clinically indicated, is going to depend entirely on the patient itself. So unless I'm changing a dose, it may only be once, maybe twice in a year, but it's always going to be on the lower side. I can't say that it's something that I've really had to do much about in the real world. I'm not sure what your experience has been like for us.
I'm similar. I do a little bit more labs than you. I think in general, we have a very large patient population on systemics and biologics, so we have a protocol we follow for everybody. But I'm quite comfortable with Sabinco. I think as we saw in the data, it's the risk factors, although there, are reasonable, and the safety profile, compared to the efficacy profile, I think is positive. So like you, I do the viral checks initially to make sure, as well as TB. I do a baseline lipid unless I have one at hand. And you know, we know we don't need to, but if I'm going to get it in a month, I think I'd like to have a baseline. So I'm not attaching an issue to Sabinco, which could be working very well. That is not really an issue for Sabinco in this case, in this patient. But I think most of us do what you do, and then we do between 3 and 6 months to a year, depending on the patients.
Love it.
All right. So listen, with this, I think I'd like to close this session. This was really excellent. Dr. Shobatia, thank you so much for giving us a great lecture. We had a great attendance tonight, and I hope you all learned a lot from this. We'd like to thank our sponsor for their support, which tonight is Pfizer. And we would love to see you at the next webinar. Thank you so much, Dr. Shobatia, and thank you all.
Bye-bye.